Afternoon. This seems to be the tumor of the day. We are removing a huge anal sac adenocarcinoma in this dog. So this is a kind of an older middle-aged beagle that has a history of a large anal sac tumor. And so I'm not sure if you guys can see it, but this is the tumor here. It's really, really big, probably about the size of maybe a lemon kind of thing. The dog is not incontinent. The owners have refused any further staging, and so we're just doing a primary excision, and that is it. They have taken thoracic radiographs to make sure there isn't obvious evidence of secondary spread, and I did a rectal exam, and there was no evidence of lymph node involvement. The owners really just want a palliative solution, although this may potentially give us an extended improvement in clinical signs. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you get a ding on your phone the next time we live stream. All right.
It's the cuff or the body down to the
So you can see this really big tumor here.
fresh gas here.
I'm going to extend the skin incision a little bit more, so we'll be able to get it out through the skin defect. Can I get some Gelpies, please, Thomas? Thank you. Alright, so Gelpies in here. And my DeBakey's. So there's a comment that the image quality is much better. This is a new camera, new-ish camera. Do you see DeBakey's over there?
Yeah.
Thank you. So it's just the camera's only about kind of 6 months old, and the other camera I have is about 12 years old, so it's no wonder the technology has improved. I think that's the duct right there. Let's see here. So I think that's the duct to the anal gland right there. Now we are going to have to remove a rather large segment of the anal sphincter, but I'm still not concerned about incontinence because I'm going to reconstruct the anal sphincter primarily. So that's anal sphincter right there. As I've stated before, I'm a big believer in bloodless surgery if you can, because your visibility is going to be much better, and so it's worth taking your time to address the hemorrhage as much as you can, because that's going to increase your visibility, and it's also going to probably speed up your surgery. And this is a big bloody tumor, so I'm not sure how good a job I'm going to do overall, keeping it blood-free, but so this dog will have no antibiotics, either before or after surgery. There's no reason for this dog to have antibiotics. And that's my big soapbox, is that we really need to reduce the amount of antibiotics, or the number of antibiotics that we use. When you're starting a patient on antibiotics, you really need to think about whether that's necessary. Gee, this is a big tumor. I'm sorry, Annie, can I please get some number 4 Gelpies? Thanks.
These are actually 4. Can we get 5?
These are not. These are 3s.
Oh, we're out of 3.
when we were out.
Yeah, we were out of 3, so these are 4s.
Definitely 3s.
Oh yeah?
Yeah, they've been mislabeled.
What size do you need, sorry?
4s, please.
4s?
So that's the gland, or the sac right there, and that's the duct coming up there, coming through the skin there. So I'm going to isolate that and transect it. Do you see a right angle forceps? That's a big one. I need a little right angle forceps. There it is. You don't need to ligate the duct.
I only got one set of 4 Charles, or I've got 2 bucks.
We'll take the 2 5s, please. Not sure if I'll be able to use them, but these are a little bit small here. So that's the duct that I've isolated there. And I'll just transect it.
Nope.
And I'm sorry I won't be able to, the monitor is quite far away from me, so I won't be able to answer questions very well as I'm going, but I'll definitely go back at the end. Maybe I'll be able to answer most of your questions just during the process of the procedure. So, I'm not getting a huge margin on this, and that's intentional. So this is what's technically would be considered a marginal surgery, which means that margins are going to be grossly complete, microscopically probably complete, because these don't tend to be terribly invasive. They tend to expand rather than invade. Let's get the other, number 5, thank you. Hey?
Do you want the 5s out as well?
Those, just these guys, yeah. Yeah. And I really like operating on tissues that are under tension. I think it's a lot easier to dissect through planes and stuff if the tissue is slightly stretched out. Now I'm going to get to the point where I'm not going to be able to get exposure of the deep surface, and so I'm going to have to figure out what I do in order to get this thing out, because right now I'm being really careful with my dissection and addressing all the bleeding, but when I get around to the other side, it's like the dark side of the moon. No pun intended. And it's going to be harder to be really careful with my hemostasis. I'm just getting my finger around behind it now. Can I get a ligature, please? Thanks, Annie. And the risk of incontinence here, I don't know if I mentioned it before, is virtually zero. As long as you maintain, the innervation to one side of the anal sphincter, you're not going to get incontinence. You might get transient something or another, but not long term. So I'm just bluntly dissecting with my finger here, and I'm establishing some planes of dissection that I'll cut through with my ligature. And I really don't like doing normal dog anal sacculectomies for just anal sacculitis, but I quite like these anal sac tumors. They're challenging to get out, and I know that I have to cut through anal sphincter, so I'm not worried about, and I know that they're not going to be incontinent. Whereas when you're doing normal dog anal sacculectomies, they can be challenging to dissect that anal sac out of the sphincter.
Do you ever use a Lone Star retractor for these?
I don't have Lone Star retractors. I imagine that it could be helpful, but I quite like my Gelpies. It's just what you're used to using. Extremely low. In fact, I've never had one become incontinent to my knowledge with this type of surgery.
What antibiotic treatment were you sent home for?
So no antibiotics to go home. And I'll take that ligature, please. I think it's been delivered. Thanks, Annie. starting to loosen up a little bit. And I'm so sorry, Annie, you're going to have to go back around and plug in the ligation. Hey?
A bolus first. It's just quite reactive, so we'll do a French bolus.
Okay. Do I need to stop for a minute? Okay.
We'll go 4 mics per kick.
Thank you. So it's really starting to loosen up now.
Do you do a lot of instrument change after removing the tumour?
So good question. Do I do an instrument change? I do not if I'm confident that I've gotten a clean excision. If there's any question about my completeness of my surgical margins, I will do an instrument change.
Yeah.
My feeling is that if I've cut into tumor, it's probably going to be in the incision, and the instruments are kind of the least of my problem. So that's the caudal rectal nerve right there. And local recurrence with these is, I'm not going to say unheard of, but it's pretty rare. I mentioned in the last live stream that local recurrence with cats is the major issue. They don't tend to metastasize as much. Whereas with dogs, it's metastasis is the main issue. Local recurrence is not a major concern. I'm just again bluntly dissecting around here. So I'm going through anal sphincter here on the medial aspect of the tumor. So that's anal sphincter that I'm transecting right now. Get a look underneath here. I think that that's my caudal rectal nerve right there, unless that's rectal wall. It's kind of stretched out, so it's hard to see exactly what it is. See, there's a big vessel there. So I'm using my ligation as a blunt dissector. Just get a right angle forceps, please. Thank you. So I'm sorry that you guys can't see this, but I'm just seeing if this is rectal wall or if it's the caudal rectal nerve under tension. And if I inadvertently perforate the rectal wall, deal, but if you just let it heal by second intention. So I'm right up against rectum there. I can really feel this thing loosening up. It's about to give up the ghost.
Do you have any preference for the initial incision?
Heading down sternal recumbency with the tail pulled forward.
And how much sphincter can you remove?
I beg your pardon?
How much of the sphincter can you remove?
I remove commonly 180 degrees, so about half of it.
Any special post-op care?
So we often will put them on stool softeners for a little while, just to deal with the straining to defecate from narrowing the sphincter as much as we have to.
And is there a cheaper option than ligation?
No ligature. So you can just, just ligate and, double clamp and tie and ligate. The other thing is you can, if you look on eBay, there's a device, if you look up on the vessel sealing device, it's kind of a poor man's ligature, which costs about $250, and it's just a bipolar hemostat that will seal vessels up to probably about 3 millimeters in diameter, whereas ligature goes about 7 millimeters in diameter.
Is it battery powered?
No, it just plugs into your bipolar.
Oh,
Does it have the cutting tool as well?
No, you have to double ligate and then cut in between. The other thing you could use would be hemoclips. But ligature cuts your surgery time in probably half with most of these tumors. And we've got fairly old ligature units. The new ones are even faster at ligating. Let me just grab that bag, and I'm going to zoom out a little bit because I think you'll see better. Yeah. All right, so that's nearly out. Make sure there's nothing important in there. All right, so that's the tumor out right there. Let's have a look in there. So we've got a little bit of bleeding, but not too much. Grab that with a debakey.
How big are you talking?
Liter. Now you guys see what Anna is doing there. What I'm doing is I'm grabbing onto the tissue, and then Anna is cauterizing the forceps themselves, like that. That works really nicely at getting pinpoint bleeders. All right, so we've got colon or rectum right here. That's the wall. That's anal sphincter there and there. All right, so let's get some lavage. And a yank suction tip, please. Thank you. So I only got ligature probably about 10 years ago, and I had been operating for about 20 years before that without it. So you can definitely do without it, and I certainly am not doing surgeries now that I couldn't do then. So you can definitely get away without it. It's just a lot easier and a lot quicker if you do have it. So that's probably abdominal fat right there.
Alright.
Let's go ahead and get some suction at the bottom there.
What do you use to moisten the cautery ground plate?
We use saline. So the question is, what do we use to moisten the cautery ground plate? You have to use saline. Well, you don't have to use saline. Saline is a lot more conductive than water, and so you are going to get a better grounding if you use saline. And you could even make your own saline solution, because it doesn't have to be sterile, obviously. All right, so just to reiterate what we've got here, that's rectum right there, and that's anal sphincter right there, and right there.
That's where you close.
Yeah.
Was it? Yeah.
So just remove this just to give us a little bit more room. Annie, can I please get some 2O PDS?
Yes.
I'm just having a look around to make sure that there's no bleeding. And we definitely have taken out that caudal rectal nerve on that side, so that would have been coming in at about this level right here.
Right.
And that's definitely gone, but again, I'm not concerned about that. So what I'm going to do is I'm going to take a bite of sphincter on this side. A bite of sphincter on that side.
Can we use ultrasound gel as referral to the ground plate?
You probably can, but it's cheaper to use saline. So the question is, can you use ultrasound gel? I mean, the answer to that is probably so, but there's no reason not to use saline. My suture has gotten tangled up on itself. Which one is the one that's... Is that it? I don't know why the suture's grabbing. Push the needle back through. Pull it this way.
How do you like
Epidural analgesia would be fine. We haven't done one in this dog. I kind of want to know, and I know that they're never incontinent, but I kind of want to know if they are. And so epidural analgesia, you can cause, a loose anal sphincter. So with these, we go just systemic with our analgesia. And I'm going to do what I can to close dead space here. Cut both of these for me, please. Who is that?
Tumor is there too.
Right. Nice. Good luck with your studies. So I'm doing a slip knot here. Okay. So when you're looking at anal sac adenocarcinomas, the big prognostic indicators that we have, things that help us predict how the dog is going to do long term, would be tumor size, hypercalcemia, the presence of metastasis at the time of diagnosis, possibly tumor grade or appearance histologically. I will just run this as a simple continuous the rest of the way up that little tissue plane.
Would it be good to use the internal, internal obturator muscle as you were doing a perineal hernia surgery? Is that something you consider?
If I was worried about having created an abdominal hernia, then I certainly could do an internal obturator flap to close the defect. I'm not worried about that in this dog. And I'm not aware of any of my patients developing a hernia after this procedure, so it's not something I would normally think about.
I know you don't often place drains, but could you explain the criteria that would make you lean towards drains?
So drains, I really hardly ever use them. The things that would make me think that a drain would be appropriate would be if I had a really large pocket. Can I get or a really large pocket of dead space that I couldn't manage otherwise. But you see, on my YouTube channel that I use a drain maybe in 5% of my cases, if that. Just don't think that they're necessary in most cases. And they're going to increase your risk of infection. And the infections that develop are going to be resistant because they've had this foreign body in there the whole time. Like I rarely use them even with axial pattern flaps.
Can I get the left sponge? The left sponge?
So good question. How can I make sure I didn't perforate the colon or the rectum? I would just see leakage of feces, and I am looking out for that. Also, just being aware of my anatomy. Can I please get some 3-O-monosin? I'll just leave Anna to finish this up. And I'll come over and make sure that there aren't any questions that I haven't.
Yeah, I think that's fine.
There is insert tray if you want.
Is it?
Just see that it's not narrowed by too much. No, that's fine. So I can get my pinky into the rectum without any problem. So I haven't stenosed it or narrowed it at all. All right, so I'll just come back over to the monitor and see if there are any questions that I haven't answered. I'm just going to step outside for a second to get my glasses. Hanging my loops on their charger. Grabbing my glasses here. And coming back into theater. We'll just come around to see any questions. So, Ryan, I don't think that we're planning on any new VetDojo content as far as new modules, just because James and I are just so busy with other aspects, and so that has taken kind of a back seat. And I apologize for that, but it's just so labor intensive to do one of those modules. So I think I've answered most of the questions. So the question, preference for initial incision for the anal gland surgery, I usually go oblique over the gland. It is an adenocarcinoma. No antibiotics to go home. And yeah, I'm just watching the video on the monitor here. The video quality is so much better with this new camera. I'm really pleased with it. So anyway, we're doing intradermal suture pattern right now. That's Anna, is the star of the show right now. And I'm going to go ahead and end the live stream. So thank you very much for watching. I've got a fairly busy day tomorrow and the next day, so hopefully I'll have lots more streams to do this week. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. We'll talk to you again soon.